Hi, everyone, and welcome. Although we're almost at the end of it, happy National Social Work Month. I hope you've been having a good one. I'm Sally Guy. I'm the Director of Policy at the Canadian Association of Social Workers. I am very happy to be moderating this webinar. It's the second part in our two-part series with Dr. Fantas on moral distress, and this one's titled What Now? Multi-level interventions to reduce moral distress and heighten self-care. So first, I just need to acknowledge that our national office in Ottawa is located on the unceded territory of the Algonquin people. It's land that we now call Ottawa, and that we are very lucky as settlers to be here on this land. So I did mention that this is the second part in a two-part series. So I imagine that a lot of you are here after attending the first part. But if you missed part one, you can find it and watch it either on our website under continuing education or on our National Social Work Month website, which is socialworkisessential.ca. Just like last time, this one is really well attended. There's been lots of interest, which speaks to how much this topic is, unfortunately, so resonant with social workers all across Canada. On to the quick housekeeping, the widgets on your screen. So these boxes, like the one that I am speaking to you in, they can all be resized and moved around. The boxes at the bottom of the screen, the little icons, that's where you're going to find everything you need, like the slide deck, links, resources. So check those out to find stuff. The certificate of attendance will be sent to you automatically to your email a few hours after the end of the presentation. Of course, this presentation will be recorded, and you can get it on demand anytime on our website beginning tomorrow. So like usual, the first part is going to be a formal presentation from Dr. Fantas with a question and answer period at the end. So type in your questions in the Q&A part of the Q&A widget at any point through the presentation. There's also going to be a lot of opportunities to engage with Dr. Fantas and each other in the chat throughout the presentation, so stay tuned for that too, which I see lots of folks are already using. We can see where you're all tuning in from. It's wonderful to see you. Okay, on to introducing Dr. Fantas. I know many of you were here last time, so I will do a slightly shortened bio, but you can read her full one on the registration page. Dr. Fantas is a professor in the School of Social Work at the University of Texas at Arlington. She did her PhD in social work and bioethics from the University of Toronto in conjunction with a joint center for bioethics. After her doctoral work, she did a clinical ethics fellowship at Baylor College of Medicine. She is a certified healthcare ethics consultant, and she studies experiences of moral distress among indirect healthcare workers, which, of course, includes social workers. She recently ran a 3-stage pilot study examining moral distress before and then during the pandemic. And her main objective from that is to develop evidence-informed strategies to help with this issue and just to enhance social workers' well-being. So with all that said, it is now my great pleasure to pass the proverbial mic over to Dr. Fantas.
Thank you so much, Sally, for everything, for organizing, for hosting, for all the work that you do for CASW. And it's great to virtually see everybody. Thank you so much for tuning in and for being here. For those who were not able to join for part one, you can watch the webinar, but I will also do a very brief sort of introduction again on what we mean by moral distress, the consequences around moral distress, and moving into the so what. In part one, there were a lot of amazing questions and great dialogue about, well, what do we do? We know this is happening. What now? And this is kind of the basis of my presentation today, to talk about what next? What can we do? What tools can I give to all of you to maybe take back to your agencies? And so before we kind of get into the lecture style, if you will, conversation, I just have a few questions just to get a sense of you all and where you're coming from and things like that. So in thinking back all the way to March 2020 to today, do you feel your workplace is less stressful, more stressful, or the same? And when I say stressful, it doesn't have to be ethical stress. It can be occupational stress, emotional stress, just stress in general. So I'm going to give you a few seconds just to answer that and just to see where everybody's at. So 81% of you have said it is more stressful. Oh, 77. The numbers are shifting just a little bit, but as you can see, it is greatly leaning towards more stress. And that is what we are seeing in anecdotes, in my conversations, in my research, my conversations with health social workers, as well as social workers across various fields of practice. Even though my research is done for hospital and healthcare-based social workers, this is happening across the spectrum. And so this is something that's really kind of obvious with your responses right now. And so what I want you to think about as we move forward is when you think of ways to alleviate that workplace stress, what comes to mind? And this, I want you to just use the chat, right? I want to hear about what you do to alleviate some of that workplace stress. So I see creating strong support systems, listening to music, coffee with coworkers, supporting each other, checking in, debriefing, lots of debriefing, exercise and healthy diets, go for a walk, a massage, human connection, supervisor, hitting the gym, going out for supper. I love all these, never skipping lunch. I love that response. And I think what you're all saying is just so important in terms of what I'm going to talk about, where ways to alleviate stress might look very interpersonal based on having folks that you trust, having folks that you can talk to, that you can debrief, but also things that you can do for yourself and understanding your own boundaries. And so this is exactly what you're doing, are things that I'm going to start talking about. And so over the past week, have you done something to heighten your own self-care? And I'm just going to give you a response of yes, no, or you're not sure. And this is just over the past week. %74% of you said yes. So that's really important and something that I'm going to talk about over the course of this presentation, of things that you have to do on a weekly basis, on a daily basis, in order to heighten your self-care. So I'm so happy to see that 74% of you said yes, and that you have done something over the past week to help yourself. And the last question, then we will get into things, is, and you can use the chat for this, what words come to mind when you see the term or you hear the term moral resilience? Maintaining strict boundaries, debriefing, seeking supervisory report. These are all great. Now I have to scroll down. Advocating for myself, flexible thinking about challenge and difficulty, ability to bounce back, courage, self-trust, acceptance, fortitude, ethics, flexible mindset. I love these. So you are all kind of on the right track. And no, but I just wanted to get a sense of where everybody's at and how everybody thinks about these terms. And so in moving forward, for those who weren't at part one or may need a little bit of a refresher, just so we're all on the same page and start from the same place, moral distress comes after an ethical dilemma has been resolved. So there's an ethical conflict and the conflict is resolved, but it's not resolved in the way that you individually think is moral or ethical. And because of individual or institutional factors that constrain your ability to execute the action you perceive as morally justifiable. So what that means is you are asked to carry out a task that really conflicts with your personal and or professional values or ethics because of individual or institutional constraints. So that might be constraints in your organization, that might be professional competency constraints, that might be certain things that prevent you from doing what you think is the ethically right thing to do. And so what happens when moral distress occurs? we have what's called negative stress reactions. And these can be kind of divided into very different realms. So there's the physical. People have talked about getting headaches, heart palpitations, GI symptoms. So you get a little butterflies in your stomach or a tummy ache, sleep issues. You're overtired, you're exhausted, you have insomnia, you can't sleep. Then there's emotional reactions. So that's the anger, frustration, guilt, anguish. Psychological. Many people have talked about panic attacks, disassociation, anxiety, and depression. And then occupational reactions, job dissatisfaction, disengagement, apathy, feeling jaded. All those things are negative stress reactions that obviously can come out about stress in general, but are also very attuned and specific around moral distress and morally distressing situations. And so these are often hidden symptoms. And many folks across disciplines, obviously my social workers and from the research that I've done has been in the health field, but people tend to combat moral distress silently. They don't want to talk about it. And that happens for many reasons. A lot of it is around the shame, the discomfort, the moral anguish, questioning yourself of should I be feeling this? Maybe I got too involved in the patient or my client. So you start having self-doubt, powerlessness. Many of us are in hierarchical positions in organizations where maybe we don't have a lot of power to advocate for ourselves or to speak up. Maybe there's a lack of managerial support or supervisory support. But there's also a lack of language and understanding. When I started to do my research around moral distress, a lot of the social workers I spoke to had never heard that term. But when I described the term and talked about it, they were immediately like, yes, I feel this. Yes, this is happening to me. So without that language, it might be really hard to define what you're feeling or what you're experiencing or where it's coming from, which makes it hard to really have those solution-oriented approaches and to think about this. And so what happens when you deal with it silently and it's not being talked about is something that's talked about in the literature called moral residue or the crescendo effect. So moral residue is when repeated or unresolved moral distress builds over time. So if it's not talked about or debriefed about or resolved, the repeated incidents and events keep making it bigger and bigger and bigger. And these long-lasting implications have huge ramifications on occupational and psychological well-being. And I really like this diagram. It's from Hamrick and Epstein. They're both very big scholars in the field of moral distress. They talk about how there's a new baseline. So when you experience moral distress and it's not resolved, the next time you have that experience, there's a new baseline. And so you keep having these same negative stress reactions that continue to build and build and build. And what winds up happening is not only this crescendo effect, but these long-lasting ramifications on professional efficacy and satisfaction, on workplace attrition and high turnover rates and absenteeism, lessen the investment in quality patient care, saying, well, I'm not going to make a difference anyways, right? Withdrawal from colleagues and peers, and even so much as job resignations, departures from social work, or the discipline that you're in. We have seen an enormous amount of social workers leave the healthcare system because they're not only resigning from their jobs, but they're departing from the field altogether. And some of them don't even want to be social workers anymore. And that can stem from this moral residue if it's not talked about, if we don't actually identify it. And those are some of the things I brought up in part one. And so where do we go from here, right? And this is the purpose of this presentation. And I know a lot of you are ready for it and want those practical tools. And hopefully this will give you some, and hopefully we'll still have a dialogue afterwards about all the other things that maybe could happen or how difficult some of these are. So there have been conversations, I would say, about how do we deal with moral distress. But predominantly it's been in medicine, and predominantly it's been with nurses and physicians, leaving out allied health professionals, leaving out social workers, and leaving out disciplines outside of health. And especially when we think of COVID-19, we think of all the morally distressing situations that happen across organizations and across disciplines. So one approach in nursing is often called the 4 A's. So you ask, am I experiencing moral distress? You affirm, yes, I think based on all these sources and triggers, I am experiencing moral distress. You assess, How bad is my moral distress? Should I be experiencing moral distress? What's going on? And then act. I'm going to act to alleviate my moral distress. And that's really helpful, but it's only helpful in a very specific environment because it's mainly for nurses. It's only been really disseminated among nurses. And so this is really not that, I would say, helpful or informative or even relevant for social workers. There are some hospitals that have had moral distress consultation services, but those are for very academic, well-resourced, large healthcare systems that not only have a financial investment in ethics and moral distress consultation services, but are also big enough and connected to medical schools, to universities, to those type of organizations. There might be unit-based ethics facilitation, and then there might be other things like educational programming, helping to enhance interprofessional communication and advocacy efforts. So what I'm going to do kind of moving forward is talk a little bit about what we mean by moral resilience, and then what my narratives with social workers have talked about. What have the social workers on the ground that I have talked to in my research have stated that would help alleviate or lessen or reduce their moral distress? And this is all to talk about moral resilience, because I think one of the nice things about moving forward is that we know moral distress happens. We know it has these negative stress reactions. Let's take away focus from the negative and concentrate on strength-based solutions, right? Concentrate on what next. What can we do to alleviate this? And that's where moral resilience comes in. And so Cinda Rushton, who's at Johns Hopkins, really kind of coined this term moral resilience. And it's defined as the capacity of an individual to sustain or restore their integrity in response to moral complexity, confusion, distress, or setbacks. So very much in connection to what many of you wrote in the chat, right? It is about this idea to deal with ethical conflict, to deal with ethical dilemmas with a higher level of competencies, with more integrity, and with more in line with your professional code of ethics. And so moral resilience may help you to identify your intentions as it relates to your professional and personal values. So really knowing your intentions before you even walk into certain cases. Your moral responsibility. What is my moral responsibility? What do I hold in this position? And then how to navigate ethical dilemmas or conflict when they arise. So having those skills in which to deliberate when ethical conflict happens. And so what are some of those key characteristics of moral resilience? And again, this is taken from Rushton's. Cultivating mindfulness, right? Learning to self-regulate, self-awareness, moral sensitivity, ethical challenges and principled actions, willingness to take action, meaning in the midst of adversity, preserving one's integrity. And these are all wonderful characteristics of moral resilience. Sometimes they seem like, okay, well, how do I actually do that, right? But I think one of the things that this is missing is that this is very individual based. And I see this a lot if I connect this to our self-care conversations, right? When I asked before about what you have done to alleviate moral distress or what you have done to heighten your own self-care, a lot of it was on that individual burden, that individual responsibility. When we ask for self-care, we say, what can we do for ourselves? But what we leave out, and this is my argument, is that self-care is the responsibility of our organization. It's a responsibility of our interpersonal connections. It's a responsibility of our managers and supervisors. If we are the ones experiencing moral distress, if we're the ones experiencing burnout, compassion fatigue, exhaustion, should it only be our responsibility to instill self-care? Should it not be group work, team-based approaches? And when we think about the pandemic, we are undergoing shared trauma and collective grief. And so what do we say when we have to take this on ourselves? There's that added stress and guilt. And I'm sure many of you might be able to relate that sometimes you feel guilty about not doing self-care, right? You're exhausted. And then you become more exhausted because you don't have time to self-care. And then you start feeling guilty that you haven't done self-care. And then it becomes this endless cycle of becoming more exhausted, becoming more burnt out, because you have on top of that responsibility or that burden of not undergoing self-care because it's all on you. And so the reason that I think social work is so unique, and I really want to pick up on social work, is because how do we make the time for moral resilience and our own self-care when our responsibilities are twofold. We're not autonomous individual players. We work on a team. We are team players and oftentimes interdisciplinary support systems. So how can we care for our client and our client's interests and their own grief and trauma and suffering, while also promoting the emotional, psychological, and spiritual needs of our collaborating teams? Because I can tell you that during the pandemic, social workers across the board were being confronted and asked to not only care for patients and families, but to also care for teams experiencing moral distress, experiencing grief. And so I'm not asking this based on our burden, but is our own well-being and self-care being hindered by the questions and the demands and the responsibility of us being pushed in so many different directions of having to care for others? And what happens is we wind up pushing our own care and our own moral distress aside and saying our responsibility is to all these individuals. And what happens is we then wind back up to that moral residue, that moral crescendo. And so I'm here to kind of talk about what can we do for that. And so just some of the things that my social workers have shared and that maybe you have heard is the worry about speaking up about moral distress or saying, hey, I need to concentrate on my own self-care, are things that we hear around mental health stigma as well, that toughen up. That's just part of your job. This is what you signed up for. Isn't this what you do? You're a social worker. Not sure if any of you have heard this. I have. Or can you just handle that? Well, that's not my part of my responsibilities. Just handle it. I just want it done. Or my favorite is process it on your own time. And that's where that self-care comes in, right? Do it after work. Do it on the weekends. Process it after work. You have a job to do. And so what I'm going to do now is I'm going to break down, ways to alleviate moral distress and sort of that overlap with self-care across 4 distinct stages. And so one is the individual strategies, and that's what a lot of you talked about, right? That self-care, that exercise, taking care of my puppies, right? Going for walks, enjoying nature. So some of my folks that I spoke to, and this is kind of coming out of the narrative, so I didn't want to be so focused on methodology or research. This is really sort of narrative-based of the stories that I've heard, is seeking therapy or even spiritual counselors. Many of my social workers relied on their faith and their traditions to kind of keep them aligned. Positive success stories. I know we talked a little bit about that in part 1, but reflecting on those positive cases, reflecting on that idea that I've changed at least one person's life and I'm going to concentrate on that. Remembering and recalling the meaning of your work, the reward of your work, why you went into social work in the first place. And then also listening to your body, whether that's through spending time with family, physical exercise or mental exercise, reading, travel, taking time off work. And that can be really, really challenging. But some of those were around mindfulness and meditation, just spending time with the kids, just going for walks and enjoying yourself, taking that break, taking time off and doing what you enjoy, whatever hobby that looks like outside of work. So I call that self-care, right? And that can be a way to alleviate moral distress, and it could be a way to alleviate a lot of the other work stressors happening in our lives. The second individual strategy, though, is forming boundaries. And I saw a lot of you talked about that too, that ability to create boundaries. And that's that internal mechanism where if you have the language of moral distress and you understand the sources of moral distress, you can then learn to draw attention to the triggers. This case seems like it's really triggering to me. This might be a way in which that it's telling me that moral distress might happen. Work-life compartment, so that's compartmentalizing, right? I saw a lot of you write about that, saying work is work and my life, my home is my home, and I do not talk about work at home. I remember my life as an ethicist was very, very challenging at times, and I remember physically having to kind of debrief after work. So I would talk to folks before I left, and then I left and I walked home and I listened to a podcast or I listened to music, whatever mood struck me. And then I was able to kind of go into the house and be in a different mindset because that physical idea of walking back home from work gave me that time. I know a social worker who works in the health system who has different shoes, different clothes, and she changes in the car and leaves her work shoes in the car, and she does not bring them into her house. So whatever that looks like for you. And then when you draw attention to those triggers, what it looks like at work. Do you need to remove yourself from the situation? Do you say, I can't handle this case, actually, I need to give it off to somebody else? Do you have to pause and reflect and say, I need to go for a walk for a minute just to think about this case? You have to identify the parameters also of professional competencies. Sometimes we're asked to do things that go beyond our professional competencies. And oftentimes we're told that that's a weakness if we can't do it, right? We're a failure. We're told to toughen up, just figure out the solution. But I think we need to normalize and say that it's okay to identify the parameters of our professional competencies and say that is beyond the scope of what I can do. That is beyond the scope of my practice. And so internalizing that is a really important strategy. That's an individual strategy because only you can know what your parameters are, how your work-life compartmentalization looks like, and what triggers are important to you and when to draw attention to those triggers. Then what many of you talked about are the interpersonal team strategies. So one of those are collegial support, so peer debriefing, support, reliance on trusted peers, to have the provision of feedback, to have role models, so those who maybe have been in the field for longer. And these are fellow social workers oftentimes, right? They're colleagues, they're mentors, they're people who understand what you are doing on the ground. It's also the creation of safe spaces, and I use plural because there is no one safe space for everybody. Everybody has a different definition and a different idea of what safe space means for them. So it's the creation of safe spaces depending on what you need and what that looks like for you. And many of the people I spoke to just talked about having to vent, just having a minute to go into their colleague's office and venting about a case and feeling better about it afterwards. And I think sometimes we see venting as negative, but venting can be really positive and really informative for so many people. Beyond collegial support is managerial support. Unfortunately, for many of the social workers I speak to, there wasn't good management styles. They were managed by people who were not social workers. They felt as though their managers did not support them, who always had to talk to somebody who was above them or who had other responsibilities. And so what wound up happening is what I talked about was, well, what does a good manager look like? What would a good supervisor look like if you could have that? And so they wanted to have adequate supervision and mentorship, which they felt they did not have consistently. And this was kind of across the board. And they talked about how managers, to alleviate their moral distress, should validate their emotions, should have time to debrief, should be easily available, supportive, and empathic, should be knowledgeable about the profession. Many of them wanted their managers to actually be trained in what social workers do and knowledgeable about what they do on a day-to-day basis. To have integrity, accountability, and be solution-oriented. Try and have collaborative and responsive ideas to what's been going on. I think many times social workers will vent or talk to supervisors about what's going on. The supervisor will be available and supportive, but not necessarily solution-oriented. And the social worker would say, well, what now? They've supported me and that's great, but now I don't have a solution moving forward. And many of them actually asked for managers to shadow them, to have that on-the-ground knowledge, that they just wanted their manager to see what they did on a daily basis and to shadow them, even if it was for half a day, to see what they did. And so managerial support is just so important and crucial as well to alleviate moral distress. And the final interpersonal team strategy is just interdisciplinary support. Many folks didn't feel like there was cohesiveness on their interdisciplinary team. So they talked about, after a morally distressing situation, to have either small group debriefs or even whole team debriefs where the social worker is not leading the debrief, but actually an active participant in that. Safe spaces to share and receive input on what could have been done differently, maybe what they wanted or what the team thought should happen. Team cohesiveness and support, and to repair the silo work. So many social workers, and I would love to hear from all of you, feel that their work is siloed, right? They're a part of an interdisciplinary team, but then they also feel like their work is siloed and not really understood, and they're kind of working independently. And so they wanted to kind of repair that silo work and really build cohesiveness and team collaboration. Back to that powerlessness, many of them wanted to be heard and validated by the team, to build strong community and relationships, and to have that shared responsibility, especially going through the pandemic. So this shows how important not only our individual strategies, but our interpersonal support can really help alleviate moral distress. And then there are the systems level strategies, right? That culture and climate that we talk about a lot, right? A lot of social workers wanted a shift in power and hierarchy dynamics. They wanted to see missions and aims from their organizations that align with their social work skills. They wanted systems to outwardly embrace interprofessional perspectives and not have just kind of one field of discipline at the top. And I'm sure in healthcare, we kind of all know who those individuals are. They wanted there to be inclusive of competencies of social work and giving allied health professionals a seat at the table and leadership roles. And that can be really challenging. I know we talked about that a little bit in part one of how do you even get a leadership role? How do you even advocate for yourself when there isn't a seat at the table? But this is what folks said. They said, how are decisions being made without us at the table? If there's going to be change, if we're going to alleviate our moral distress, we need to be at the table. We need to be there. And then obviously integrating mental health support into their mission, into their aims, outwardly showing that they support mental health and well-being. And I know that this is a lot, right? This is a lot, and it's not something that can be dealt with or solved in one day. And it's a lot sometimes beyond our control. But I want to show how ingrained moral distress is to take away some of that individual responsibility where it's not just you. It's not your fault. You have nothing to blame yourself. Don't have self-doubt. This is a multi-level, complex system that creates morally distressing situations. Some folks talked about educational initiatives, and I think this one is just so important, right? To cultivate that shared language, especially within shared trauma after the pandemic, to bring in that language of moral distress into educational initiatives across teams. In service education for interdisciplinary training, how many social workers did I talk to who said, my team doesn't even know what I do? They say, figure out the discharge plan, figure out insurance. Why aren't they discharged yet? Why is this taking so long? But they don't have a minute to say, what are you actually doing? What does your day look like? Why is insurance so complicated? Can you explain that to me? And so many folks just wanted some continuing education to teach folks about what social workers do, what's their role, that we're more than just give bus passes and vouchers, that we do so much more than that. And that was a really big component where they felt if there is just more education and more familiarity with the real job and competencies and education of social workers, they feel that there would have been more respect. Interdisciplinary job roles and responsibilities, so gathering that interprofessional dialogue, teaching how to have dialogue with others. Medical school and residency curricula, so obviously this is very focused on healthcare, but I mean this across fields of discipline. Wherever there's going to be a discipline education that interacts with social workers, the responsibility, the jobs of social workers should be ingrained in that curricula. Involve palliative and hospice education so that end-of-life conversations aren't happening last minute and aren't being rushed. And support interdisciplinary team training. So many folks talked about wanting to just have time with their team and build that strengths training, build that collaboration, build that cohesiveness. And then financial investment. And this is obviously a big one depending on the organization you're at, depending on how much funding and resources they do have. And I know that in the time of the pandemic, it is not great. And there's always real limitations. But again, if we're talking about reality and we're talking about feasibility, funding for mental health promotion, funding for more staffing, funding for leadership initiatives, funding for continuing education and conference attendance. So I had folks, so in my research, I also interviewed chaplains in spiritual care. So that's why faith and spirituality come out in some of my conversation. But there was one individual who said, can you stop giving money for parties and, lunch? Give me money so that I can have continuing education, so I can go to a conference, so I can learn more. To have funding to promote wellness and mental health, and to have financial investment in programming and resources that support well-being, that show that social workers are valued and appreciated. During Social Work Month, I do have one story where a social worker talked about this, and she was talking to me and she said, I just wanted an email. Do you know that I was interviewing her during Social Work Month, and she said, it's Social Work Month and nobody has emailed us. Nobody has emailed us a thank you. Hey, it's Social Work Month, or an acknowledgement, or anything from leadership, from administration. Silence. And she said, if they had just sent an email, even if it was just a generic, thank you for all your hard work that you do, it would have meant so much to me, like I was valued and respected. And so that doesn't take funding, right? But that takes time, that takes thought, that takes reflection on the fact that even just a thank you email can mean so much to so many folks. And so that's what I mean by promoting wellness and mental health, that yes, folks want to see it brought into their job description, right? They want to see it in the contract they sign for their employment, but they also just want to see it that we care about you and we care that you're here and you're not just a number. And then this actually is very social work specific. I want to bring up macro level approaches. So many of the social workers I spoke to talk about advocacy and social justice. And I know that this was a question in part 1 where there was a conversation around, how do these macro level systems of oppression kind of play out in moral distress? And they're obviously there when we think about families who have lower socioeconomic status, who are uninsured, who are undocumented. Those conflicts might come up and there might be more constraints available on what the ethically or moral decision is, right? That you can't do that based on policy constraints or practice constraints. And so one of the things that my social workers talked about was volunteering time and having a commitment to their professional code of ethics beyond work. Whether this was choosing a charity or an organization or an initiative that really spoke to their own passions, whether it was around health insurance, health disparities, social determinants of health, structural racism, they kept asking, how can you get involved? What can you do outside of work that builds in that passion, that alleviates moral distress? Because maybe you're constrained in your job. Maybe you are constrained by doing the ethically correct thing for one individual. But what can you do outside of that? How can you maybe be one voice in a system that we know needs change, that we know needs something different? And so that was something that comes up that I don't think our ideas of moral resilience really touch upon yet. This idea of those macro level initiatives that we can talk about. And so I ask you, when you leave this webinar, how can you get involved? What can you do? There is so much going on in our world right now. I know that, so it's hard to choose just one. But think about the ways that maybe you haven't been involved that might give you some sense of meaning, of reward, of stuff outside of trying to make that difference. So, for example, I spoke to a lot of social workers who just really got distressed with discharge planning around those who are uninsured. And so they took time outside of work to find initiatives that helped those who were uninsured, who helped raise the healthcare system, right? Who gave change or voice to have a reformed healthcare system, especially when I'm coming from the United States. And so that was something that helped them saying, at work, I'm constrained, but I'm doing stuff to try and change the system of why I'm constrained. And so that's just something to think about moving forward. And so if we think about the next slide that I am attempting to pull up, there we go. Here are some innovative strategies that folks have talked about that I've thought about. And obviously it does in reality depend on funding, depend on your organization, but education on advanced care planning and end-of-life decision-making, or whatever triggers or real sources of conflict are in your organization. Continuing education and having education ingrained in your organization and training is so important. Using ethics committees, ethics consultants, there's bioethics hotlines, getting folks involved to help debrief, to help have those conversations. I think I saw in the chat somebody say, well, we have somebody external come in. That is so important. Having an external person who is not a part of the institution can be something that's really, really helpful. Having a consultant come in to have those team debriefings, to talk things through is really critical, because I think a lot of organizations try and put somebody in internally, whether it's another social worker from a different department or somebody internal. But when we go back to that first slide about the self-doubt, the powerlessness, the shame, the distress, fears of your reputation or your status, you're not really going to have those really in-depth, clear, transparent conversations. And so something to think about that is as well presentations for health systems and the public about moral distress, because it's not just social workers and professionals who are experiencing moral distress. We are experiencing moral distress in wherever we are. Parents are experiencing moral distress in choosing whether or not to send their children to school or daycares. It is happening across the board. Caregivers are experiencing moral distress of whether or not maybe to send their older adult parent to an adult day home or to a nursing home, especially in the pandemic, and feeling constrained by these choices and feeling like they're not doing everything that they can to help care for their loved one. Continuing education, grand rounds. There is something in hospital systems called Schwartz rounds. And Schwartz rounds are really sort of an emotional and psychological debrief round where you talk about a really challenging case and you have an interdisciplinary team that's a panel talk about the case and debrief their perspective. And those who attend have questions, provide feedback, debrief about it, ask follow-ups, but it's the ability, the purpose or the aim of Schwartz rounds is to have the entire disciplinary team as a panel talk about their own perspective or experience going through that morally distressing case. And so that provides kind of a more formal setting in which to actually have a debrief conversation. And you can bring in the public, you can bring in anybody from the organization is invited, and you kind of talk through it. And so that's a way to do it as well. And those were really highly utilized when I was working as an ethicist and also in my time talking to social workers. Systems level dedication to mental health and well-being. We talk so much about well-being, mental health, but we don't actually see it put into practice. And that can really create just looking at your organization and asking yourself, is this an ethical workplace? Do I work in an ethical place? Is this an ethical environment that I'm happy in? And so with that, I want to end and draw time for questions, but I invite you to use the chat if you wishes. Moving forward after this webinar, like what's a practical tool you are going to take with you? Or what are you going to do to pursue your own moral resilience? And you can write in the chat or you can use the Q&A, but I do want to thank you all and take time for questions with our 15 minutes left about.
Oh, well, we can watch those answers come in. I'm sure folks are typing them now. Before we get to questions, Sophia, I want to say thank you for this presentation. Once again, just like the first part of this presentation, so much engagement in the chat, so many different topics coming up. There's so much sharing, so it's going to be exciting to dive into questions. I want to say to the audience that, of course, we're getting sort of some similar questions, so I'm going to try to sort of combine them together a little bit, the ones that fit together categorically for Sophia to answer. I'm just going to dive right, actually, unless, Sophia, you want to look at some of these people.
I'm trying to scroll. We can dive in, but I also just want to thank all of you. I mean, not only thank you for attending, but during Social Work Month, thanking you for what you do. So many folks don't realize how hard it is to be a social worker and a social worker during a pandemic. And I think in speaking to some folks, especially in Texas, is the pandemic's over, right? It's over. We're living in the aftermath. And I think what we tend to forget is, one, we are still living in a pandemic. And the second is this is long-standing side effects and stress and trauma and grief that is going to carry with us for years to come. And so even though it might seem like we're in the aftermath of a pandemic or beginning our endemic, we cannot forget what we have been through and how that moral residue is going to continue even long after we go back to some return of normalcy. So I do want to say that, and I do want to thank each and every one of you for the work that you do. You are validated and you are appreciated.
Oh, well, I'll ask you the question and you can keep an eye too on the chat, which is still pouring in. This first question is right along the lines of what you were just talking about. Something you didn't touch on, but I think is related, is the issue of morale. So I'm just going to read what the question is, or it wasn't even a question, actually, it was a statement, but I think it dovetails into a question. So this person says, as a healthcare worker, we have so many rules, such as, having to have distance lunches, no food sharing, no celebrations, which has made our workplace community evaporate. So I'm wondering, so like Dr. Fantas, if you can speak to how the pandemic, and many of the ongoing precautions that it has necessitated, some of which I think may be permanent at this point, how does that morale change impact moral distress?
Such a good question. And please call me Sophia. Everybody should call me Sophia. But um, yeah, I think yes, so it has. And as an academic, right, I am completely isolated, right? Like I basically work from home and I just started teaching back in person like this semester, but I taught online for the last 2 years. It completely impacts morale because you can't collaborate with one another. You can't engage with one another. That feedback has to be a Teams meeting that you arrange a week in advance that is exhausting because everybody is Zoom fatigued and still forgets to unmute themselves. I know I do on like a daily basis. And so I think that does impact moral distress, not in a way where I'm not sure that it would be a trigger of moral distress, where it would be, you're constrained into doing something that you don't agree with. But I think what it does is it creates that moral residue, because what you're doing is you don't necessarily realize that it's happening or that you've experienced moral distress. And because you're unable to have those side conversations, pop into somebody's office really quick, have that chat over lunch, that moral distress is going to sit. And so what it actually does is I don't think that it would be a trigger of moral distress, but I think it definitely connects to and impacts our moral residue, because we're less inclined to that if we are experiencing moral distress, and I say this very generally, we're less inclined to say, hey, can I make a Teams meeting with you so we can, or can I call you? That feels very formal. And that feels like that would take a lot of energy. That sometimes when we're experiencing moral distress, we are all at our limits. We don't have a lot of energy left in us. And so when I talked about that venting or that peer support, many of my social workers that I spoke to talked about how easy it was because they shared an office, how easy it was because that fellow social worker was down the hall, how easy it was because when they went to a different floor, they would bump into somebody and chat really briefly. And so that's how it's impacted it. I think we're going to deal a lot more with moral residue or moral crescendo because we don't have that ease of access, because we don't have that ability to pop by our colleague's door and say, hey, can I just chat with you really quickly? I just had this experience and I have this thing. Because at the end of the day, or when we actually have time to make that call to our colleague, or if we make a Teams meeting 5 days later, that's going to dissipate, right? You're like, oh, it wasn't so bad. Oh, it was okay. I'm feeling a lot better now because it happened. And you kind of had time to pause, maybe not reflect, but you've moved on to the next case, right? Because we're so busy and taking on so many responsibilities. You've moved on to the next crisis, but you haven't talked about it and you haven't debriefed about it. So you're not going to call that person, but that moral distress is still there because you haven't resolved it. So if you're going to have a client and that's going to pop up again, you're going to be like, oh, nope, all this stuff is coming up again with that last client that I never talked to my colleague about. So I think that's how it's impacting. And I think that morale is definitely impacting that too, because you're less inclined to, one, talk about it, and two, everybody's overburdened. That what are you just saying to yourself? I don't want to be another burden. I don't want to be another person telling somebody about they're going through enough. We're all going through that. It's part of the job, right? And so I hope that answered your question, but I think it's really negatively impacting our moral residue in ways that I don't think we even know. It's very hidden.
It's going to continue to necessitate conversations like these, make these kinds of sessions and this topic all the more important. And I see in the chat people saying, this is inspiring me to put on a presentation on this, things like that. I also just want to note, this is kind of random, semi-related, but just on the note in the chat, people were saying, and you were saying too, Sophia, just that little bit of validation can go such a long way. It does feel like we're kind of at like a tipping point where social work has been really under-recognized, but in some ways the difficulties of the pandemic has a little bit thrust it into public perception a little bit more. And like one just interesting thing that happened is, for the first time ever, CSW received a video from the Prime Minister acknowledging and thanking social workers for National Social Work Month. So it's which is a tiny, the least you can do, but is still something interesting that we are at this point of things are really bad, but what opportunities, I guess, does that offer to? I think is how, I guess, the optimist in me is trying to recalibrate.
But I think, and in what you just mentioned, he probably sent that message because of advocacy, because of the work that your organization is doing, because of the work social workers are doing. I remember us chatting before, but he probably received emails and messages and letters from social workers saying, it's social work month. Do you know what we're doing? And that it goes back to that macro level social justice and advocacy piece that I mentioned of saying, then CASW got this letter from Trudeau and, he thanked social workers, and you can share that letter with other social workers, right? And they can feel some sense of validation, but that's because of the advocacy that your organization does and individual social workers do. And that's why that's so important, because that sometimes when we think about policy or macro level social justice, we say, oh, it's at the policy level, it feels so much. But what we tend to forget, and I know this by living in the States, is macro level policies impact our individual day-to-day lived experiences. And so something like that, I think, can shape our moral distress experiences.
Okay. What do I go to now? Okay. This is a practical question. And I have to say for everyone in the audience, Sophia wrestled at length with with how to balance these sort of macro and micro issues. So I'm going to ask you a micro question. This is a Frankenstein question of many people's questions, but how can we navigate these challenging conversations with our employers? For instance, how to ask them to incorporate the strategies you discussed, like taking days off or like time for self-care or money for self-care. And related to that is, how do we communicate this kind of stuff to our managers from other professions that don't speak the same language that we do as social workers?
Yeah, that's a great question, and one that I struggle with kind of on a daily basis, because I think it is really, it's easy for me to sit on this side and be like, this is all the information you should have, and then you actually to practically take that information into your field. So I want to sort of recognize that and say that kind of out loud. I think that there are a few things. One, it depends who your managers are. If they are more healthcare like nurses, moral distress comes from nursing language. So I will say that if you are speaking for those who might be in healthcare and might be worried about your managers, if they're more the case managers or have nursing backgrounds or medical backgrounds, they might be familiar with the language of moral distress. And so that's why I talk a lot about shared language, making sure that you use language they kind of know and can associate with. The second, and this is something that I've talked a lot about with, some of my participants and some social workers, is that your own flexibility around language. And I think that, we often learn how to connect with people based on how they connect with us, right? We mimic language. We sort of learn how to communicate with certain people. If we've worked with certain people for a really long time, we know, oh, that's the sarcastic one, or that's the one that's like this. I know how to engage with them. I know they would like that joke, but this other person wouldn't like this joke, right? Like those type of things. And I mean that, in all seriousness, where you learn to be flexible in how you communicate. And so I would say that if you're trying to talk to your manager, or you're trying to talk to leadership about this, there's a lot of anger, right? But I think that we do need to take the anger and the emotions, and I hate to say this, but a step back, because the managers and the leadership are not in most places, and they look at it with financial investment. The National Academy of Medicine has stated that hospitals specifically, because they're a medical organization, but I'm sure that this is across the board, that burnout is costing hospitals billions of dollars because of absenteeism, because of high turnover rates, because of mental health support. So it's actually in an organization's financial interest to act preventatively and to care for this. And so I may not, push the door down and say, why aren't you providing me mental health support? Why isn't this happening? But come with an open dialogue and an open conversation about saying, this is what I'm seeing in the field. This is what I'm seeing among my colleagues. And I know that there is a financial incentive to this. I know that this is costing organizations a lot of money. How can we act preventatively and talk about it through a collaborative approach? It's almost like you're seeking their opinion and going to them and not necessarily blaming them for it, right? And the same thing with managers is, can I just have a chat with you about kind of what I do on a daily basis? Because I think there might be some miscommunication, or I think that there might be a misstep. I don't know whether they would have time, but you could always ask them to shadow you for an hour, right? To follow you around, or ask your organization to have a training. Hey, I'm getting a lot of the same questions from my colleagues around what I do, or about insurance, or about discharge, or whatever the specific issue is in your organization. I'm wondering if we could have a little training on it. It doesn't have to be long. It can be online if we need it to be, and have that sort of education thing. But I think trying to approach it in a collaborative way, and also trying to kind of lean on to the organization's financial investment might help. But organizations need to know that burnout is costing organizations millions of dollars. And so it is in their best interest to act preventatively. That probably doesn't answer your question to the best of my ability, but that's my answer.
Oh, we do the same thing in advocacy, and when I first started working here 7 years ago or whatever, you always feel a little bit slimy sometimes going to, like, for instance, politicians and saying, like, it's not slimy though, but going and saying, I think investing in mental health care is the right thing to do. It's the compassionate thing to do, but you go with them and present how it actually will save them money in the long term, because that is often the more compelling argument for people in different kinds of leadership positions.
And I think people understand. I have a colleague who works in the healthcare system, and she was having a really rough day, and she went to her manager and she explained what was going on, and the manager let her leave for the day, right? And so I'm not saying that all managers are like that, or all organizations are like that, but I think in our mind, there might be some self-talk sometimes that, well, if I can't handle it, I'm weak, or I shouldn't be in this job, or this is just part of the job. Exactly like that slide I showed of that internal dialogue that sometimes we have. And to say, it's okay to advocate for yourself and to speak up and say, hey, I'm feeling really burnt out and I'm worried that this is impacting my clients. Can I have a mental health day? Because if we, and this goes back to mental health stigma, if we had a broken ankle, right? If we had chest pain, we would say, hey, I have to go to the doctor. I broke my ankle. And they would be like, oh yeah, totally. But if we're experiencing some mental health burnout or compassion fatigue, we're less likely to talk about it. And so I think talking about it too, asking what support they have, asking if you're able to take even half a day off, or doing something for yourself, or saying, I just need this day, to try and normalize that as well. Because we do it so much for our clients, but we don't do it for ourselves.
We only have technically 2 minutes left, but is it okay if I go a little over, Sophie? Like, do you have like an extra 5 minutes? If I take 2 more questions? Okay, I want to take 2 more questions.
My last slide, and then some folks have to go. There's my email address and everything, so please feel free to email me.
Okay, so I promise I won't go over too much. There's 2 more that I really want to get to. So the first one is a very interesting one. How does moral distress present differently in social workers in private practice than those working in systems and organizations? And if you have any ideas for solutions or strategies for those types of folks.
That's a great question. I'm not, in all honesty, I'm not as familiar with private practice, but what I can suspect is you have your own policies and standards that you need to abide by. So it can even be feeling more constrained when, one, you don't have a team to go to, right? Or a quick referral to do. So what if it is beyond your practice or beyond your competencies and you need them to make a referral? What if there's a wait list for that referral? What if there's not one that's geographically close to them, right? What if they need a higher level of care that they can't get or they don't have insurance for? Those are some things where you don't have a team in which to work with. It's kind of just you. And then you feel like you are not doing your best. You're not doing the most ethically justifiable thing for this individual. And so that can be really isolating and really lonely because you don't have that team to go to. As much as I, in part one, like blame the team for not really, having familiarity with social work and putting down social work or not validating social work, they are helpful when you need support or you need other things or you need another specialist or something like that. When you work alone, those become exacerbated because it's so beyond your control of what you can do. I think my main point of reference would be your colleagues. So you can use many of these same things. Collegial support. Just because you're in private practice does not mean you're alone. You have colleagues, I'm sure, who are either also in private practice or in organizations that you can vent to and chat with and talk through cases with anonymity and confidentiality in mind. And also supervision. I think, we stress supervision for our students and for novice social workers. But once we get kind of years later in the field, and this is not to put anybody down or say anything like this, but sometimes we forget to have weekly supervision, right? Or we think we may not need it as much. And I think supervision, especially when you're in private practice, but in any organization, can be so helpful when you're dealing with ethical deliberations and you're dealing with moral distress, because that is beyond what one person can handle. And so having a supervisor who knows the language, who knows what you're going through, who can help you with kind of solution-focused or oriented strategies can be really helpful. So I will say those two things. I know we're kind of at time, so I'm not going to go into too much detail, but I think those two things, I think you can definitely experience moral distress through that isolation and having to rely on community organizations that might have limited resources or limits in geographical context or wherever, and as well, supervision and collegial support.
So just to be expedient, I'm going to end, as we're already 1 minute over, with just a tiny little systemic question. And it's not even a question. It's a statement that someone put in the chat that just generated a lot of interest. And I just want to hear if you have any reflections on it. I know it's a conversation I've heard come up a few times. They just said, self-care, and they put self-care in bracket, like in quotes, self-care places the burden on individual social workers to cope with systemic issues. And I just wonder if you have thoughts on that and if you could speak to that.
Can you repeat it one more time?
Yeah. So it's that self-care places the burden on individual social workers to cope with systemic issues.
Yeah. So I mean, I completely agree. I think we tend to use the term self-care very broadly and say it is your individual burden to deal with your self-care when you're overwhelmed by things that are systemic issues. So it's saying, well, you are burnt out, you need, to compartmentalize, or you need family time, when it's, no, this is actually systemic issues that are happening in our healthcare system. I see that all the time in the US, especially around systemic racism in health settings and health systems, the way in which doctors, and not to put it on doctors again, but physicians and surgeons sometimes talk to patients who might have a different culture, a different religion, a different background than them, and they create narratives based in stereotypes and negativity. I see it all the time with uninsured patients or undocumented patients. And you are saying, well, this is part of your job. You have to acknowledge your self-care, rather than what can we do for advocacy? What can we do around more macro level changes that need to happen? And I think that's really unique to social work, because I don't think other fields of discipline see it in the same way we do. I was the only ethicist who had a background in social work. And I will say that the other ethicists I work with never thought about social determinants of health, never thought that ethical conflict could come up because of distrust in the health system, because of past negative experiences, past discriminatory practices of healthcare providers. I was the one who always had to kind of be that voice to remind them. But when I had a really rough week, it was about my own self-care, or because my patients had died, or that I needed time being off call. It wasn't about, there are issues in our system that we need to challenge and we need to face. And that is part and parcel of our professional code of ethics. And I think you're right on, and I don't think people talk about it enough. So I know we're over time, but I completely and wholeheartedly agree. I think ethical conflict and disagreements and breakdown in communication between clients or patients and leadership or hierarchies, whatever have you, is rooted in systems of oppression. And so I don't think that that's talked about enough, because self-care is often seen as, oh, you had one bad day. That was a bad day. I'm like, why was it a bad day? it's a bad day because there's injustice in our healthcare system. There's injustice in our systems. And yeah, I completely agree. And so that's why I brought up the advocacy piece of there is something more that we have to do, and CASW is clearly doing it. Whatever that looks like, it doesn't have to be, knocking on folks' doors to make sure that they vote, like that they register to vote every, evening and weekend. It can be something like writing a letter to somebody saying you need to just validate social work. It can be however you choose, but that is how that can alleviate that moral distress, that more macro level engagement.
Just a fluffy light question to end on, That's what I like to do. No, so we're fully and truly out of time now. So this will be recorded. It's going to be available on the website tomorrow. Other practical stuff. Oh, the certificate of attendance is going to be sent to your email in a few hours. After this session, it's clear we probably could have done a 10-part series, but I don't know if we could keep Sophia around for that long. It's just clearly impacting social workers so deeply all across the country from the chat and from the questions. So thank you so much, Sophia. You're so busy. You're a professor, you're writing papers, you're running studies. So we really appreciate you taking the time for this. And is there anything you wanted to say in closing?
I mean, I do this work because I was a practicing social worker. My heart is in social work, and I do it to shift and change practice and to make sure that each and every one of you are heard and validated. So again, I thank you. Thank you, Sally. And I don't think Alex is online, but thank you both for organizing this, for the work that you do, and for the advocacy that you do. You received that letter from the Prime Minister because of what you do and the hard work that goes into recognizing and validating social work. So I just appreciate each and every one of you. Feel free to reach out to me. I'm always ready to engage in dialogue, make a Zoom call or a Teams call or whatever choice you want in technology. And I'm always here for you. So not a waste, not too much time at all. I always have time for this.
Perfect. I can't close any better than that. So with that, happy National Social Work Month, everybody. Thanks for being here, for your really thoughtful questions and reflections, especially in the chat. And hope to see you next time. Take care.